Hello and welcome. In today's case presentation, we'll discuss a rare but significant case of left ventricular pseudoaneurysm in a 39-year-old patient with a repaired partial atrioventricular canal defect. This case highlights the importance of long-term monitoring and timely diagnosis. Our patient is a 39-year-old male with a history of partial atrioventricular canal (AVC) repair performed at 26 years of age. He presented with sudden onset of right-sided weakness, aphasia, and facial droop indicative of an embolic stroke. The patient has trisomy 21, which complicates his clinical condition. He has not seen a cardiologist for years. On examination, the patient was febrile with a heart rate of 88 beats per minute, blood pressure of 126/69 mmHg, and an oxygen saturation of 97%. His neurological exam showed significant aphasia with left-sided facial droop and right upper and lower extremity weakness. Initial imaging, including head CT, showed thrombus in the left main cerebral artery, confirming an embolic stroke. Transthoracic echocardiography revealed a large aneurysm affecting the lateral wall of the left ventricle, LV, with possible thrombus formation inside the pseudoaneurysm. The left ventricular systolic function was mildly reduced, estimated at 45%. Mild mitral regurgitation was also noted. The TTE provided initial clues to the presence of a pseudoaneurysm in the LV. Cardiovascular magnetic resonance (CMR) imaging confirmed the diagnosis of a pseudoaneurysm with an LV ejection fraction of 40%. The cutoff sign, characteristic of a pseudoaneurysm, was evident, showing abrupt myocardial thickness loss near the neck of the aneurysm. This feature is distinct from true aneurysms, where a gradual tapering of the sac is observed. CMR also revealed pericardial enhancement around the aneurysm, supporting the diagnosis of a pseudoaneurysm. To further confirm the diagnosis and assess the aneurysm's anatomy, contrast-enhanced cardiac CT (CCT) was performed. The CCT showed a large pseudoaneurysm in the lateral LV wall, measuring 9.7–6.0 centimeters with an intramural thrombus. The CT also revealed an occluded left circumflex artery, LCX, that likely contributed to the myocardial infarction and subsequent pseudoaneurysm formation. This was a critical finding that further explained the patient's embolic stroke. Given the broad base of the pseudoaneurysm, surgical resection was deemed too risky. Instead, the patient was managed with anticoagulation therapy using apixaban to prevent further thromboembolic events. The chronic nature of the pseudoaneurysm suggested a lower risk for rupture, so surgical resection was not immediately necessary. Follow-up echocardiography showed no new thrombus formation, and the pseudoaneurysm appeared stable. At a 3-year follow-up, the patient showed no recurrent neurological events and had stable cardiac function. His neurological symptoms from the initial stroke had completely resolved, and there were no signs of rupture or progression of the pseudoaneurysm. The patient was doing well, with stable health and no further complications. In conclusion, left ventricular pseudoaneurysms, although rare, can occur in patients with a history of congenital heart defects and previous cardiac surgeries. Timely imaging and proper management are essential in preventing complications. This case demonstrates the importance of careful follow-up and the use of advanced imaging techniques for managing complex cardiac conditions. Thank you for watching. Don't forget to like, share, and subscribe for more case presentations. See you in the next video.